HYPOSPADIAS. We will see some pictures, and the other one is the EPISPADIAS. So the difference is that for the HYPOSPADIAS, the urethra opening is at the ventral aspect of the penis, while for EPISPADIAS, it is at the dorsal aspect. So one is above other, the EPISPADIAS is below. So not difficult to understand. So here there is a scrotum, so the penis is above, so there is an opening just below the penis. While for EPISPADIAS, the opening is above, on the upper aspect of the penis. So this may be associated with the other genital abnormalities. As I said in the morning, when you see a child or even an adult person with a malformation, always check other organs, because usually malformations are in different locations. So, for example, HYPOSPADIAS and EPISPADIAS, they are associated with inguinal hernias or undescended testes. So the clinical consequences is the constriction of the orifice. Constriction, it means the decrease in the caliber of the urethral orifice. Urinary tract obstruction, of course, because of that constriction, and infection, which is a consequence of that obstruction, and the impaired reproductive function of the organ. So that's all for the malformation, just we talked about it too. For the inflammatory lesions of the penis, some they are sexually transmitted diseases that probably have seen in some other courses, infectious diseases module and so on. So we have also baranitis or baranoposthitis. Here it means there's inflammation of not only of the penis but also of the scrotum, glands, and the prepuce. Sorry, it is associated with poor hygiene in uncircumcised men who have smegma. Smegma is like so ni imyanda ifata ku bantu batari circumcised. So the distal penis is red, swollen, and tender. You remember these are signs of inflammation, redness, tumor, pain, and so on. There may be a purulent discharge if the infection is purulent, of course, has a pus. So other inflammatory lesions for the penis, there are phimosis and paraphimosis. You will see most of these diseases when you are in district hospitals. So paraphimosis, phimosis, EPISPADIAS, and HYPOSPADIAS, you will see many of them. And these may be indications for doing circumcision. So for phimosis, we talk about phimosis when the prepuce cannot be easily retracted over the glands. So you see the image here. While, and this may be congenital and usually associated with the inflammation of the prepuce and the glands with scarring or scar formation. So paraphimosis is the opposite to phimosis. Here there is a trapped gland which cannot go back to as it should be. And the consequence of this will be urethral constriction and so on. So the specific infections now, the fungal infections, the one of the most common infections is the candidiasis caused by Candida albicans, of course. It is seen in immunosuppressed people, especially those with diabetes. There will be an erosive and pruritic, painful lesion on the organ, and this can involve the entire external genitalia, meaning that even the scrotum may be involved. So as I understand, if you think about this, then you will scratch a material to send it to microbiology. they will do culturing or staining first, and if they see that there are germs, then they will do culture to confirm what is there, and to do antibiogram to know sensitivity test to know which antibiotic can be used to treat that person. So the neoplasm for the penis, they are mainly the squamous cell carcinoma because the penis is covered by the squamous epithelium, and you see many cases of this. And it is somewhat associated with human papillomavirus. There is a study we have done in the different hospitals of Rwanda, the referral hospitals. So we saw that most of these are caused by human papillomavirus serotypes 16 and 18. The same as those causing cervical cancer. So epidemiologically, squamous cell carcinoma of the penis is rare, is somewhat rare, less than 1% of the cancers in the United States men. And usually this affects uncircumcised men between 40 and 70 years of age. And unfortunately, what we see in our settings is that men, they come very late. Kubera ko ari uruganda maybe abantu batinda kugaragaza ko bayirwaye, batinya, bagira isoni, akenshi baza kwa muganga igihe cyararenze, bararembye, ugasanga hakozwe amputation, rimwe na rimwe yagize metastasis in distant organs, so they die. So pathogenesis, there will be poor hygiene, nasumeduma nk'uko twabonye aho ngaho akenshi izamo germs zitera chronic inflammation. So as I said, human papillomavirus is involved in that. And first these persons will have a carcinoma in situ nk'uko bigenda muri cervix. Then it will progress to squamous cell carcinoma. The question? Okay, so let's proceed. So here we have a lesion here. It is a hemorrhagic, or it is not very much clear, but this person had the squamous cell carcinoma. So on histology here on the right side, we have a relatively normal epidermis here, or squamous epithelium, with the stroma. In the stroma, we have inflammatory cells. This is blue or black dots. These are nuclei of the lymphocytes. So on this part, you see that there are some nest of epithelial cells which are penetrating deep into the stroma, and a lot of inflammatory cells. So this is a carcinoma, a cancer. On the right side, there is no cancer. On the left here, there is a cancer. So high power, they form keratin. So this is very easy to diagnose. So the clinical course of the cancer, squamous carcinoma of the penis, is that it is usually indolent. Indolent, meaning that no pain when it is in early stages. Usually it invades locally. It has spread to inguinal lymph nodes in 25% of the cases at presentation. So distant mets or metastasis are rare. So the 5-year survival rate is 70% if this patient don't have lymph node metastasis. But when there are the lymph node metastasis, those who will survive 5 years are not more than 27%. You understand that this is really a poor prognostic disease. And you can also imagine that if now distant organs are involved, not only lymph node, but also distant organs such as the liver and so on, the survival will be poorer than this. So that's all for the penis. If there is any question, you can ask it. Otherwise, we proceed with the diseases of the scrotum. So no question? Okay, so we proceed. The regions involving the scrotum, we have inflammatory regions, such as tinea crudis. I think I mentioned this when we are looking at the dermatopathology, what is called jock itch. So jock itch, so someone has itching because of the infections by fungi in the inguinal area, and he will scratch himself or herself in a way that people they can think he or she's joking. So that's why they say joke itch. So a superficial dermatophytes infection. So and it will be scary. Usasanga ari ahantu havuvuka, reddish with annular plaques. You remember the called plaques in dermatology. This it will be pruritic. That's why it is itching. And it is usually seen in the inguinal crease to upper thigh. So ishobora gufata ku kibero hagana hejuru, then igakomeza muri inguinal area niho ikunda gufata. Akenshi hari n'icyo abantu bagira bakabinegirije bakumva ni ibintu bisanzwe bizikiza, ariko it is not an easy disease to treat. Indwara dermatologic, especially these ones which are contagious, they are not easy to treat. You take drugs for long, and sometimes urayifata bikagenda bikagaruka ukongera ukajya gufata indi miti. So other regions involving the scrotum, there are scrotal enlargement. So muzamubona abarwayi baza bafite nk'abagabo baza bafite hydrocele. So iriya each joke ishobora gufata umugabo cyangwa umugore because it is just in inguinal area. So we go back here to the diseases of men. So hydrocele, hydro means fluid, cele means here it refers to the accumulation. So there will be accumulation of serous fluid within the tunica vaginalis. So the causes are infections, tumors, or idiopathic, meaning idiopathic means the cause is unknown. So that is a serous fluid. When there is accumulation of blood in the scrotum, they call it hematocele. When there is accumulation of lymph, that fluid from lymphatics, they will call it chirocele. And this is caused by filariasis. So this I should be removed. Filariasis, that we call also elephantiasis. And then sometimes na scrotum in a photo. So other regions of the scrotum, there will be the proper diseases of the testis. So in general, when there is scrotal enlargement, you should know how to exclude some diagnosis and how to retain some differential diagnosis. So whenever you receive a man or a young boy with hydrocele, with enlargement for the scrotum, it can be either hydrocele, hematocele, chirocele, or testicular disease. Then it will be up to you to do a proper clinical examination and, if possible, investigations to know what is happening. Then, if you confirm it is hydrocele, then you will have to go beyond and say, is it an infection, it is a tumor, or is it something else? lesions and neoplasms. So the most common congenital malformation is CRYPTORCHIDISM. So hamazamona bamwe baneka CRYPTORCHIDISM ngira ngo hari abadashyiramo CH ahangaha biterwa n'icyongereza ukoresha cy'abanyamerika cyangwa icy'abongereza. So and the testicular atrophy. So crypto, this is a word which just means something hidden. Orchidism, it is something referring to the testis. So abana baba bafite testis ntabwo bari kuvuka kuko ari umwana uvuka afite testis ikiri muri abdomen ariko ikazamanuka nyuma. So biba ikibazo yageze ku myaka 2. Iyo yageze ku myaka 2 zitaramanuka nibwo you must intervene medically, otherwise murategereza. Ariko ndabana benshi babyuka testis zose zaramanutse ziri muri scrotum zombi, bamwe hakaza imwe abandi ntihagire n'imwe zikaguma hejuru. So when at 2 years the testes have not yet descended, you have to do surgery. Ukazimanura ukazifixa, ibyo bita cryptopexy, I think we shall see it. So this is a failure of testicular descent. Epidemiologically, it affects 1% of males. So this is a high percentage. So meaning that in a class of 100 males, probably one of them had this problem. So the right is more involved than the left, and in 25% of the cases, both testes are involved. And here, nobody can know exactly why the right is more involved than the left. So pathogenesis, they think it is hormonal abnormalities because there may be some hormones which are responsible for the testicular descent. Other reasons are testicular abnormalities, meaning that maybe it has an abdominal shape, therefore for it to descend it is difficult or impossible. Others are mechanical problems. So when there is inflammation which has taken place around the pathway where the testis should pass through, and therefore if there is a scar, the testis cannot pass through, and so on. Cyangwa se hari ikibazo cy'uburyo peritoneum iteye aho ngaho aho testis zabo makumyabiri and so on. So these are mechanical problems. And so if you find this, you can correct that. You can, first of all, ntabwo uzakora correction of that mechanical problem ngurekeraho kubera ko kenshi n'undi umwana uzabona umwana yaravutse, you will have to put down these testes into the scrotum n'ibyo bibazo bindi biharuka bikene. So testes are not always in the scrotum after birth. This is what I was saying. Testes are from the in abdomen with kidneys. They migrate to scrotum. So bisa naho muri embryogenesis ziba biri ahantu hamwe na kidneys. So testis zigomba kumanuka, kidneys zikaguma aho zigomba kunyura kuba muri retroperitoneum, while the testis migrate to the scrotum. So they may get stuck in the inguinal canal. If they are stuck, then we'll talk about CRYPTORCHIDISM. Complications of not repairing this problem is to be sterile. Icyo cyo kirahari, ntabwo umuntu yaba afite bilateral CRYPTORCHIDISM ngo byare, ibyo byo ntabwo bishoboka, because these testes they will be automatically atrophic. Whenever testis igumye mu nda imbere iba atrophic, niyo ukoze histology usanga nta spermatogonia zirimo, niyo turimo twari duke cyane ku buryo umuntu adashobora kubyara. So that is a problem of sterility. And then there will be an increased risk of developing testicular tumors. Cyane cyane yitwa seminoma n'izindi birashoboka. So this is a consequence. Ndetse binavugwa ko niyo itinze kumanurwa, nubwo wayimanura nyuma umuntu afite imyaka 10 n'ingahe, risk zo kugira cancer n'ubundi zirakomeza kubera ko umwe yaratinze kuyimanura. So other complications are inguinal hernia. So atrophic testes secondary to orchidism, CRYPTORCHIDISM. So they are atrophic. Atrophic, you must be having a reference So here there was a ruler which helped to know the size of the testis. So the clinical course, when unilateral, you may see atrophy in contralateral testis. You understand the consequences. So the testis which is in abdomen, it will be automatically atrophic. But the problem is now, if even the one which has descended will be atrophic because the other one is still in the abdomen and atrophic. So sterility, as I said, and the risk of malignancy will increase from 4 to 10 times as compared to those not having cryptorchidism. So Teratoma twavuga ni oruchidopexy cyangwa oruchiopexy. So ijambo idini wakunda gukuramo. So oruchidopexy or oruchiopexy, it may help to prevent atrophy cyane cyane ikorewe igihe, but may not decrease the risk of malignancy. I was saying this. So the other problems, icyo bakeka gishobora gutera this atrophy, the chronic ischemia, inflammation or trauma. So other causes are not, these are causes of testicular atrophy. Itatewe na CRYPTORCHIDISM. If there has been a chronic ischemia, ibikunda kubaho hari abantu bagira ira inguinal hernia aho intestines zimanuka zikajya muri scrotum. Hari ubwo zimanuka zageramo zikihotora, rimwe na rimwe zigatuma na testis yihotora, then ikagira ischemic. Hari n'ubwo testis ubwayo yihotora, so torsion, atari uko habaye inguinal hernia, nabyo bijya bibaho. I remember when we were at medical school, hari umuntu wari uzwi cyane mu mujyi wa Butare yeza azana akana kagize testicular ischemia ndetse zari zabaye necrotic, bayikuyemo ko nta cyari gikoze. So others are inflammation. Tujya tubona kenshi abantu baza bafite tuberculosis muri testis ntabwo ari bake barahari. So birumvikana iba atrophic. Another reason is traumatism. Another reason is hypopituitarism. So niba zitari muziko pituitary gland if the factors which influence other endocrine glands to enlarge and so on. So if there is hypopituitarism, therefore the stimulation of the testis may be low, and therefore the testis will not enlarge, will not be of a normal size. Another reason is excess female sex hormones, which can be therapeutic. So abagabo bashobora kuzihabwa kubera ibintu barwaye runaka, biranashobora ko hari abazifata kubera ibibazo byatewe by'ubu abatinganyi n'ibiki byose bashaka guhindura ibitsina transgender and so on. So bose ushaka gusanga bafite atrophy. So another reason is cirrhosis, where when someone is having liver cirrhosis, in liver there is much synthesis of female sex hormones, meaning FSH, LH, and FSH. So these, of course, because they are antagonistic to the testosterone, they will work negatively on the testis, and testis will have a small size. Other reasons are malnutrition, irradiation, chemotherapy, and so on. So ibyo n'umuntu mukuru ashobora kubigira, irradiation muziko muzamubona muri radio iyo bajya gukora radio, ikintu cya mbere umuntu uyikora nubwo ubu birinda hanini, ariko hari ubwo barindaga genital areas kurusha ahandi, hariho yambara akantu gakinga yankoreye zikamugeraho. So these rays are not good for health, especially for gonads. So gonads must be protected. So this was atrophy and also CRYPTORCHIDISM. So inflammations of the testis. So testis and the epididymis, the muzikoziri hamwe akenshi infection ibifasha hamwe ifata n'ahandi. Niko dukunda kurana iyo tubonye umuntu afite tuberculosis, usually it affects both. So usually involves the epididymis first and they go then to the testis. Usually, these are sexually transmitted diseases, gonorrhea, chlamydia, and so on. So also there are other non-specific epididymitis and orchitis. Orchitis meaning the inflammation of the testis. And this may be secondary to urinary tract infection, meaning that someone has developed a urinary tract infection, but because, for example, urethra, of course, it doesn't pass through the testis. Ariko musico urethra receives a tube coming from the testis, so it is very easy for bacteria to go through urethra and then go to the epididymis and the testis. It can be bacterial or non-bacterial, caused by parasite, by fungi, and so on. So, what will be the clinical manifestation? The child or a man will come with a swelling of the testis and causing, of course, the swelling of the whole scrotum. It will be tender, just the signs of inflammation. And if you do histology, you will find that there is acute inflammatory infiltrate if this is caused by bacteria. Otherwise, we will see macrophages or lymphocytes if it is caused by the microbes. So one of the most fearful inflammatory condition for the testis is mumps. Mumps ni ibyo bita amashamba niko babyita. So usanga abana babyimbye amatama cyane kubera ni virus ifata muri salivary glands, igafata muri pancreas, ikaba yanafata muri na testes. So niyo mpamvu bazavuga nubona umwana w'umuhungu arwaye amashamba uzihutire kumuvuza, otherwise the testes may be affected, akazaba sterile kandi kubera ibintu bya negligence biri aho ngaho bakunda kugira. So 20% of adult males with mumps they will have their testis involved also. So mumps akenshi zigarukira kuri salivary glands, kabyimba mu matama, but in some cases it can go in 20%, it goes to the testis. So I mean edema and congestion, chronic inflammatory infiltrate, because this is a viral infection, so you have a lymphocyte, not neutrophils. It may cause atrophy and sterility. This is what I was saying before. So tuberculosis causes granulomatous inflammation and caseous necrosis. As I said, we see not few cases in our hospital. Autoimmune granulomatous their findings in middle-aged men. So autoimmune, it means that some antibodies directed against somebody's parts or organs, such as testis. So vascular related diseases, I had mentioned torsion. So you see that this is black because there is a gangrenous necrosis. It can be caused by torsion, it can be caused by venous compression, or just hemorrhagic infarction, or necrosis of the testis. It is most in young men. Usually ntawe ubizi impamvu habaho torsion cyane ikunda kuba nijoro kandi umuntu aba aruhutse, but nobody knows why it happens in the night. It is very, very painful. Sometimes it can be reduced by itself. So torsion yatangiye ugasanga iri mu bwayo nta hatagombye intervention, surgical intervention. Any questions so far? Okay, so we proceed about the scrotal masses. The scrotal masses, they can be caused by, okay, yeah, referring to swelling, not inflammation. So they can be caused by testicular tumors, which are usually solid. So whenever you find someone with scrotal mass and you palpate, you think first about testicular. It can be epididymal lesion. So epididymas is affected by inflammation. I have not seen a person, an patient with epididymal cancer or benign tumor. They are almost always inflammation. So if you palpate and you feel the testis is normal, the epididymas is painful, then think about an inflammation of the epididymas. If the mass is not within the testis, or mass, think about the testicular swelling, which is either hernia, meaning hernia for scrotal hernia, and hydrocele, and also if it is vascular in nature, then think about the maybe vascular tumor. So hydrocele here, you can do action using just a needle and see how the fluid is. So if it is, for example, you can see if it is framed, especially if you send it to microbiology, they will tell you that there are inflammatory cells and so on, and sometimes can isolate bacteria. So the testicular neoplasms, epidemiologically, this is most important cause of painless enlargement of the testis. So here there is a hint also. If there is a testicular enlargement and it is not painful, think about a tumor. Don't think first of an inflammation. So 2 out of 100,000 males in the United States, this is the incidence. The whites are more affected than blacks. And there is increased frequency in sibling, meaning that is a problem with heredity. The peak incidence is between 15 and 34 years of age. So most of the testicular tumors are malignant. So very few will personally the cases I've never seen a benign tumor of the testicles. They are or malignant. Those associated with them, say development. For example, if there has been torturidism, as we said before, these will are prone to develop testicular cancers. Others are those having testicular dysgenesis, especially men, if you can say so, men with additional X chromosome. So, and as I said, most are pregnant, but they have excellent results with treatment. Ngirango mwise muri hematopathology, some lymphoma called the Barrett lymphoma. Iyo cyangwa se testicular tumors is an emergency. It emergency because patients can be completely cured. So reporting vuba then bavurwa vuba. Kimwe n'abafite bita Choriocarcinoma, it is a cancer rising from placental remnants. So some germline, others are non-germline. So meaning they arise from the reproductive cells, mitochondria and so on. So those from germline component, the examples are seminoma. So in nomenclature of the tumors, this you think that it is a misnomer. So how the name appears, you can think it is benign from seminiferous, but it is not. This is a cancer. The embryonal carcinoma is a choriocarcinoma. So men can develop choriocarcinoma because this is a embryonal, meaning that horizontally undifferentiated, which can differentiate itself into tissue looking like for the placenta. We can have a choriocarcinoma in men, and sometimes we have Leydig cell tumor in women. Like Leydig cells, they exist in testes. So we can have some have a mixed pattern. You can have someone with carcinoma on one side, the embryonal carcinoma on the other side in the same test. So non-germline tumors, they can come from supportive cells because spermatogonic cells or spermatogenic cells are supported by other cells such as seratory cells and this Leydig cell which is synthesize testosterone. So what here is said is that 5% of oral testicular neoplasms, they are from germ cells, so meaning that they are germline tumors, and mostly these are intratubular germline neoplasms. They can rarely arise from serous or Leydig cells, and these are benign. I'm not seeing them, except in women. In women have seen Leydig cells. Lymphoma also exists in men, especially men aged more than 60 years. So the WHO classification of this is World Health Organization classification of testicular tumors. First of all, you have to say if the tumor is of one histologic pattern, and these are constitute 40% of all the tumors. So the most common among them is Seminoma, others are Embryonal Carcinoma, yolk sac tumor, Choriocarcinoma, and Teratoma. Others have multiple histologic patterns. So Teratoma mixed with Embryonal Carcinoma, Choriocarcinoma with pattern, or many other combinations. So what is the histogenesis of testicular tumors and their peak incidence? Here, I think we are talking about germ cell tumors. So it can know that these germ cells they can differentiate into gonadal aspects. Therefore, where we have a seminoma, so seminiferous tubules, and here we can have seminoma, which is seen in men aged 40 to 50 years. And here we can have potential differentiation. Potential differentiation, it means the cell tends to differentiate, but it can still be differentiated into any type of cell. So therefore, it can even differentiate into a muscle, into an epithelium, into a fat, and so on. So this will be over the time known as seminomas, such as which is poor and differentiated and seen in the 20 years. Forever, so trophoblastic differentiation, as I was saying, we bring about choriocarcinoma, yaratwise agira icyo bita invasive more cyangwa se deform more yose zikavamo choriocarcinoma. Ataba n'ubundi mu bagore ku bagabo so is yolk sac differentiation. Yolk sac nimwe bavuze kare ikuzwamo ubundi bintu bitunga embryo. So hari amasira akomeza gukora igisa n'icyo kintu cya sac, ngo yolk sac mu cyongereza bita sac vitale. So this will be having tumor marker called alpha fetoprotein. So if we measure alpha fetoprotein in the serum cyangwa se kuri tumor ubwayo tukakoresha antibodies, take that and it is positive, it is a confirmation this is a yolk sac tumor. While for choriocarcinoma, we measure this human choriogonadotropin, nayo ubundi bapima ku muntu twite ariko afite normal value. So iyo bibaye byinshi cyane bakeka heredity form more aba byinshi enze indicators bashyize bakeka ko ari choriocarcinoma, then they will on to do further testings. So they can have a somatic differentiation. Teratoma, and as you saw in the female genital system, teratoma tumor has many types of cells. ibiva ari amaserire ava kuri embryo, endoderm, mesoderm and ectoderm, then uzasanga umuntu ari umufite teratoma ye ifite amaserire ya epithelium, akagira gastrointestinal tract tissue, nervous tissue, skin tissue, cartilage, smooth muscle, bones, amenyo byo yabonamo ari ibishigo ari byose ukayibonamo muri ovary, so nta muri testis birahari. So a teratoma can be mature, all the tissues are just well differentiated, like normal tissues of another person. It will be called immature when some cells are undifferentiated, and is considered a cancer. So it is a cancer and is highly aggressive. So here there is an image, say hemorrhage. I think we can appreciate it, but maybe necrosis is not easy to appreciate here. Another one, you see that it is lobulated here. It forms like lobules. So seminoma, it affects the young men, 40 and 50 years. This is the peak incidence, the peak age. It can affect of even younger men. It is curable when we diagnose it. We straightforward the physician to care for that. So it arises from sperm-producing cells, and there are several histological tests. There are no markers you can measure in the serum to know this person, just as a screening tool or diagnostic tool. So this is how a normal testicular tissue appears. Tubule, these are seminiferous tubules. These are nuclei of spermatogenic cells. The membrane here is reddish. So spermatogonia and differentiated ones, they are very close to the basement membrane. As they differentiate, they come closer to the lumen. Sperm cell, spermatozoid zirimo hagati, binazibashisha guhita zifata inzira zigakomeza zikagera muri kugenda zikazajya epidermis, zigakomeza muri deferens, then gasohoka hanze. So they will be sorted by territory. Zazirimo hano nizo zizanira ibitunga and so on. While Leydig ziba ziri muri hanze ya seminiferous tubules, zitukura cyane, will be the Leydig cells. So then you see that you can recognize that this is a higher power. Recognize that these cells are of spermatogenic origin, but you no longer see the seminiferous tubules. You see septa between different parts of the tumor. So this is how seminoma will appear. So high power. So here we have seminoma, and here we have syncytiotrophoblas, and you know this is one component of the placenta. So meaning this person has developed a choriocarcinoma because it's a component of syncytio or trophoblas, which are components of the placenta. So embryonal carcinoma is very aggressive, affecting men around 20 to 30 years. Here they have done a cut section. You can appreciate the hemorrhage, and here necrosis can be seen. Layers of hemorrhage and necrosis, two histologically distinct cell types. So there are some markers which can be used. Ariko ntabwo ziri specific. So no specific markers. Hari ibyo ushobora kureba fetal protein ushobora kuzamuka or not. They are not specific. So in it, you can have some aspects which appear as hands here. Otherwise, other areas they look like the seminoma. Choriocarcinoma, it has a placental elements, as I said, syncytiotrophoblas, and this they synthesize this hormone, this pregnancy hormone. So it will be very high, and this should not be seen in men, of course. So if you find it in men, about of a choriocarcinoma somewhere in the body, not only this can be. So this is highly aggressive. Akona choriocarcinoma usanga ifata abagore yihuta cyane, nayo ndasinabivuze iyo extreme urgence, kubera ko aba barwayi barayikira burundu, ushaka gushwanyaguza uterus. Akenshi igaragara ashwanyaguza uterus, but when you diagnose it, bakora metastase, bagakuramo uterus, bakamuha imiti, arakira burundu. Ndetse n'igize metastase mu mwijima bamufata nkaho atari ikibazo, nabo baramuvura. Ariko iyo metastase igeze mu bihaha, then no hope for that patient. Immature teratoma, this what they are showing here is that you have a teratoma on one part, and the other part you have embryonal carcinoma. As we said, these tumors, they will be just concomitantly seen in one region, and this is 60% of the cases of testicular tumors. So the dermoid cyst will be very differentiated or mature teratoma. The ifite components of the skin only. So iyo tubonye ifite components of the skin, ninga ukabona gayo, ukabonamo imisatsi, ukabonamo sweat glands and sebaceous glands, byo gusa ushaka kwita dermoid cyst. That when there are muscles or internal organs, tissues, then we will call it teratoma, not dermoid cyst. So, as I said, the cells, the three germlines are usually both represented. Ectoderm, murabizi ko skin, the appendages, and central nervous system. So, ectoderm ivamo cyane the organism that GI, gastrointestinal, the respiratory system, and mesoderm are supporting tissues, muscles, fat, cartilage, and the bone. So here we have the cartilage, for example, in this section. So Leydig cell tumor is one of several called specialized stromal tumors. It is non-germline, of course. Usually they are benign, these tumors. So it is a hormonal active because, as usual, Leydig they synthesize androgens, but also they can synthesize estrogens. And in this case, you find someone here, gynecomastia. Sometimes have this corticosteroids in the body. So what is the clinical cause of the testicular tumors? So they usually present as painless lesions in our and there will be an enlargement of the testes. They can be presented with metastasis. At the time of diagnosis, the metastasis is already there. So non-seminomas are the most commonly associated with metastasis. So you find that the liver, the lungs, the lymph nodes are affected. So the seminomas go just in the regional lymph nodes. The tumor markers, as we saw, they are the beta HCG, choriocarcinoma, and the alpha fetoprotein, mainly in the yolk sac tumor. Treatment success depends on the histology and the grade, the stage. Of course, seminomas and choriocarcinomas respond very quickly to the treatment, I said, but others are not. So seminoma are very sensitive of radiotherapy and chemotherapy. So written here. So the tumor markers, I think it is a concept that you saw in the general pathology neoplasia. Some tumors produce agents can be measured in the blood or the urine. Some are embryonic tissue markers. Can also beta HCG, which is a placental marker. And this, as I say, it is the one you want to pregnancy test ni bareba. So iyo umuntu ayifite iri detectable bivuga ko atwite in the normal ranges. When the ranges are higher than normal, then ukabibona, you think about a more invasive, a identifiable more. When the levels are too increased, then think about choriocarcinoma. Alpha-fetoprotein is associated with embryonic gut or gastrointestinal tract. So that's all for the testis. So we covered the scrotum, the testis, and the penis. So the next will be prostate. If you don't have any question. Any question? Okay, so let's have a 10 minutes break. Then. I hear you. Okay, let's have a 10 minutes break. Then if someone was about to ask a question, you will ask it after.
umugore ari kureba ukuntu umugabo ari gufata
Why don't you show me how your inhaler works?
Mm-hmm.